This conference will now be recorded.
Hello, everyone. Welcome, and thank you for joining us for today's ACRM Pandemic Webinar, which is part of a series of webinars produced by ACRM and its community groups to help bring needed information to rehabilitation researchers and providers regarding the use of telehealth during the pandemic. My name is Tracey Wallace, and I'm the co-chair of the ACRM Pandemic Task Force, as well as the ACRM Technology Networking Group, which is the community group that came together with ACRM leadership and staff in the early days of the pandemic to initiate this webinar series. And I'd like to personally invite those of you who are not already members to consider joining ACRM and the ACRM Technology Networking Group. Today's webinar was developed with collaboration from the ACRM Brain Injury ICIG. We appreciate the time and effort the ACRM Brain Injury ICIG leadership has given in support of this, and we especially thank them for recommending today's speaker. Today's webinar is episode 10 in our series and will be presented by Dr. Mark Pedrotty, who will discuss guidelines for safe delivery of rehab services through televideo, as well as use of televideo to train and provide case consultation for rehab service providers. Before we get started with Dr. Pedrotty's presentation, I do want to advise that this meeting is being recorded, and I'd like to ask all attendees to keep your phones or mics muted and to keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have questions, please type them in the chat feature and we'll address as many of those as we can during the later part of the hour. And with that, it is my great pleasure to introduce our guest speaker, Dr. Mark Pedrotty. Today's presentation is titled Use of Televideo in Rehabilitation Medicine, Guidelines for Safe Delivery of Therapy and Case Consultation. And we are very thankful to you, Dr. Pedrotty, for accepting our invitation to present. Dr. Pedrotty is a senior clinical psychologist and professor in pediatrics in the Division of Physical Medicine and Rehabilitation at the University of New Mexico Health Science Center. He is the program director and founder of the Integrative Cognitive Rehabilitation Psychotherapy Project Echo Clinic, which provides long-distance training and mentoring for rehabilitation service providers. Dr. Pedrotty has extensive experience providing specialized training on the identification and treatment of brain injury in survivors of domestic violence. He has served on the board of the Brain Injury Alliance of New Mexico and has engaged in telehealth services for over 20 years. So we'll now turn the presentation over to Dr. Pedrotty. It's a great honor to have you speak today, and we look forward to the presentation.
Thank you, Tracey, and actually the honor is all mine, and thank you and Dr. Berquist for inviting me to give this talk, as well as coming up for the title. I was in a panic trying to figure out how to make a title for this, and Tracey did a great job kind of helping me with that, so thanks. So we'll just kind of get on with this. As you all know, well, first of all, disclosures, I have no financial disclosures, and I'm a member of the APA Division 22, and Rehab Psych and Program Director of the Integrated Cognitive Rehabilitation Psychotherapy ECHO, and the board member of the Brain Injury Alliance. And the objectives today are to describe how to screen for risk long distance, describe how to manage risk long distance, describe the format of Project ECHO for long distance training and mentoring, and describe unique opportunities and challenges resulting from using Project ECHO, and describe how Project ECHO is being adapted to address the COVID-19 pandemic. So, as you all know, we've all been kind of thrown into this. So COVID-19 and telehealth is like this perfect marriage is the question. You know, is it a shotgun marriage? What kind of marriage is this? We were all sort of bopping along, and all of a sudden everybody's dropping into telehealth. So for people who've been at it for a while, you can basically talk about, well, okay, we've been doing this for a while, and it's pretty cool. And there's an article from Perle, in 2011 that was suggesting that telehealth has been around since the 50s in some ways. And here, I was basically using it back in 98 or 99 when we just had a little, what was called an 8x8 box you put on top of a TV set and plug in TV and the phone line into the box, and you probably had about 15 minutes of talking, and then it would freeze up on you. So things have come a long way since then. So it seems like this is the perfect time in a lot of ways for telehealth to really just get going. We've been talking a lot about it, but now it's really taking off, I think. So really, we want to ask some of the questions of what are the benefits of using telehealth now? Obviously, keeping people alive is a primary benefit in making sure we're not contaminating each other. But there's other possible benefits to it as well. And the question is going to become, as COVID-19 resolves, how will we all be still doing telehealth in a way that just sort of jump-started the system? And then we also want to know and talk about what are the barriers and negatives to using telehealth now. Certainly, there's a group of people who are comfortable and just jumping in there, and then there's a group of people who are sitting there trying to figure out if this is the right format for them, or do they have the right technology, or do they have the right resources to do this? And so we have to begin to ask how it can be not that helpful for some groups. And so in the big picture, the question is, are you ready for this? So are we ready to jump into this and get going? So this issue about risk assessment is definitely a look before you leap. For those of you who jump off cliffs into water and wonder as you're going down if there's rocks down there or not, this is a good kind of time to slow that down. For those who are super cautious, this is something that can make you a little anxious because there's a lot of details, and hopefully some of the information provided today will allow you to organize those details. And certainly the talks prior to this one kind of laid out the technology, the billing issues and things like that. And there was a component on it from speech on how to use it as well. So hopefully this will provide some further information around that. So basically what I'd like you to do is just consider the issue of what telehealth has done is it made us go from just hanging out in our clinics and getting things done in our clinic with the team around us to all of a sudden moving that to a person's home. So the questions are, how are safety issues identified prior to a visit to your clinics of practice before you even did telehealth? I mean, what were you aware of? What was everybody doing for you when people were coming in? So what did you already know was going to happen? Or if a crisis happened, then basically who managed that? So what safety issues are managed in your clinics or practice? So this is the whole gamut. I was talking to a pulmonologist and we're talking about risk, and she was saying, wait, yeah, sometimes people have either some asthma issues or some problems with breathing, and it might get into a crisis, but in the clinic, we manage it. So I have to then know what to do about that if it's happening during the session and it's long distance. In my world, psychology, one of the questions is just basically, if someone gets really suicidal, what are we going to do? And so you have to begin to ask all these questions. And so then you're asked, okay, so if there is a crisis in your clinic, who is there to help? How are they managed? Do you call a code blue? Do you basically call a colleague to help? Do you call security? What do you do when you have a crisis in your clinic? And so now you begin to walk through it and say, okay, so what am I going to do long distance? How do I put this in place? So I just want you all to think about how the community that you're stepping into can be your support. And then what protocol do you have in place to manage those issues long distance? So that becomes the next few slides that we'll talk about, is how to do that. So there was a prescient article in 2011, a review by Perle et al. On telehealth. And I'm going to read some of the stuff. I know that's a no-no, but some people, they might not have access to the screen as much. And I'm not going to just sit here and have a 20 seconds of silence. So anyway, what was really nice about this is that they kind of set the stage for what needs to be done to make telehealth ethically and culturally and from a business administratively safe and useful. So they basically, there's a quote, a psychologist should educate themselves in all aspects of the new models of intervention, that is ethical, legal, evidence-based treatments before using them. And there is no evidence that online therapy cannot be conducted with clients in crisis situations, nor is there more difficulty in locating a client in online therapy compared to telephone crises. So that's really good. So prior to beginning, a psychologist may gather information including where a person is located, crisis contacts, family members and friends who can be reached in case of emergency, and other important information. So this is the part where we have to do our work. And it can feel odd when you first go to do this. And finally, it is a psychologist's duty to ensure the safety of clients in online settings, regardless of geographical differences. So this means that your homework that you have to do is a little different than if you're in the office. You're not asking if there's a code blue team around. You're not asking where's security, how do I reach them? Now you're trying to figure out in the community what's available. So now we have to problem solve on that. Now, the APA guidelines, the American Psychological Association, came up with guidelines in 2013, and they've just made some updates as far as how does this fit into COVID-19, but the guidelines are still the same. And so I just pulled out two core of the guidelines for telepsychology. And there's number 2 with standards of care and delivery of telepsychology services. And so basically it states, psychologists make every effort to ensure that ethical and professional standards of care in practice are met at the outset and throughout the duration of the telepsychology services they provide. And then guideline 3 is informed consent. Psychologists strive to obtain and document informed consent that specifically addresses the unique concerns related to the telepsychology services they provide. When doing so, psychologists are cognizant of the applicable laws and regulations, as well as organizational requirements that govern informed consent in this area. Now, for me, here at the university, I rely on the Center for Telehealth to help me with this. So they provide some forms that I use, and I'm sharing them with you at some point after the presentation, I think. There's consent forms in Spanish and English, and I think in Vietnamese. And there's 2 components to it. One is just the standard using Televideo, and the other one is using a smartphone, because smartphones can be a little tricky. And so you have to kind of explain some of the nuances of smartphones and how they can be hacked if you're not keeping up on them. So it's just, so this part about basically making an informed consent form that actually is thorough enough to cover everybody is important. And I know with COVID-19, there's been this discussion about being able to do phone consults or doing therapy sessions on the phone, and there's been some relaxing of some of the rules, but I think it's real important to at least have this standard way of talking to people about using this platform. So these are just some risk management guidelines that I've put together, and then you'll see when we look at the APA checklist, it's kind of put together for you in a different section. But what I really want the take-home message to be is that the first thing is, it's very important to do your homework. So for me, when you're looking at risk assessment, you want to begin to ask just the simple questions about your client, and that is the age, the gender, the diagnosis they're running with, the location, the contact information, the address, other involved professionals, which I think are really important, because then you get a sense of how big the circle is and how frequently they're seeing them and who's responsible for what, and possible and actual safety and medical risks. So for those who do behavioral medicine components, there might be some of the medical issues that are part of what you're talking about, and you might have to figure out if they need to be going to the emergency room or something, if they're really having some sort of crisis. And then from the psychological point of view, if they basically are having thoughts of harming self or other, or they're being abused, or they're becoming psychotic, what are you going to do about that stuff? And so, you can ask the simple questions. Do they already have a history of this? And if so, what's been the outcome? And if not, then are the things you're talking about, are they going to stimulate that or not? And then how are you going to put a handle on that? And then there's a third one on, if you've never met the person before, you collect as much information as you can, and then you kind of do a risk evaluation that way, with always trying to be cautious. I use safety first, and I work my way out from that, and then you want to look at insurance. One of the examples of this, when I first was using telehealth a long time ago, and this was my wake-up call, is I was doing a long-distance therapy session, and it was an intake, and so intakes are kind of hard to do, I think, telehealth, for a number of reasons. But anyway, I was seeing it was a child and his mom, and the child, I talked to the child for a little bit, and then the mom wanted to talk alone, so I talked to the mom. And then the mom began to reveal that she was suicidal. And, you know, my blood pressure and my heart rate all went up. And I'm like, oh, this isn't going to go well, because there was somebody at the site, but if I just started having these odd thoughts about what if this person really just begins to lose it right now? I have not put anything in place. I don't know anything about this mom. I was very, very cavalier about it. Fortunately, after I asked her a few questions, she says, no, I'm seeing a therapist and we're working on it. And I was just like, wow, okay. So I basically dodged a bullet at that point. So really it allowed me then to say, I really do need to do my homework, because I don't want to get caught in that kind of dilemma again. So knowing a lot about where they're at and how to begin to walk through this with them, we'll get into that when we talk about how to do the consenting with them. And also, you have to look at cultural and ethical issues. The cultural issues are just part of how does technology work with the people that you're working with and where they're at. Here in New Mexico, some people don't have good access to basically internet, and some places have very good access. Some people can afford it and some people can't. And if you're hearing a beeping in the background, it's I guess a fire alarm that they're doing, but I think it's a practice, I hope. So there's never a dull moment. And then you're looking at safety support in the community, contact numbers and personnel, availability, accessibility, pre-appointment contact information. And then you want to look at the comfort with telehealth technology as well. And so in the safety of the telehealth technology and the billing and charting issues. So I'm going to go outside because they're making me, I can't believe this is occurring. This is kind of odd. So just give me a second. And I'm just going outside so we can finish this. I was joking with Tracey about, what are all the things that could go wrong, and I didn't think of this one. So, are we still on? Can people still hear me?
I still hear you, Mark.
Okay. See, so we got lucky. All right. So then the other part is billing and charting issues. You really want to talk to whoever you're talking to about billing and charting to make sure that the insurance companies and things that you can do the right coding and that it's going to be accepted. With where we're at right now, a lot of the stuff is being accepted, obviously, because we're in a crisis. And you need to make sure you document it correctly in your charts. If you're going to do telephone, at least where we're at, we have to write down telephone. And if you're going to do televideo, you write down televideo and then you use your coding, but you've already seen some of that stuff. So getting the consent guidelines is really the next step, where you've already made your game plan and now you're calling the person, you're beginning to just clarify these issues with them. Now you can do this with a pre-session call just to establish if the telehealth is a good fit or not. I mean, if they're comfortable with it, if they have the right technology. And some people would rather do telephone than televideo and vice versa. So if you have the flexibility to work with them on it, that's great. And if you're talking to them and you haven't really had the chance to get them all the forms and stuff, then you might begin to talk them through it. But if you can get them the forms, like at the time you're talking with them or soon thereafter, you can begin to walk them through the consent forms, or you might have to call them back. Or at the time of the session, if you determine that the session's okay, at the time of the session, you work through the consent form. So some people are trying to get the consent forms done ahead of time, which is, if we weren't in this pandemic, that would be the appropriate thing. But because of the pandemic, sometimes people might not be able to get those things in line as quickly. And so what we're going with is, if you can at least document a verbal consent, or if they can email you a consent to say, yes, I read it and I agree, and I'll mail them into you, then that works as well. So you want to get the consent signed, or verbal consent on use of telehealth. And you also want to know about calling the emergency personnel in the area if needed, and the billing issues. So basically, if you know it's high risk, I encourage people to track down who the sheriff or the state police are, and who the fire department is, and things like that in the community. so that if you have to call, you already have that number on hand. And you've already, you can call them ahead of time and just say, I will be providing some services in your neck of the woods. And if I need to call, then this is what I'll need. And is that okay? Some services are very grateful and say, yes, we're glad you're here. And you don't give people's names. Once in a while, the service will say, oh, we know who that is because, you know, we see that person all the time, because you didn't tell them, but they already can guess. And you don't have to acknowledge that, but you can just say, I'm glad. You can also get the family to consent to talk to the locals if it's a really kind of a chronic and crisis kind of case. But you want to get this stuff ahead of time, because there's been people trying to call 911 and then they realize that 911 is only in their own area. And so then they're kind of stuck because now they don't know how to get 911 in the other area. So, so in those situations, you just want to at least make sure you know what's going on, so that you can get that done without being in a panic. So what you're also going to do when you call them, you confirm the number in case you get disconnected, including if there's an available backup number or person to contact, and the address, any of the local care that's in the area, accessibility to the care, and then any needs or other relevant details. I will ask if there's guns in the home and if they're locked up or not. Because if I call and if it's a psychiatric crisis, they're going to want to know if there's guns in the home. So those are some of the things that we do here, or that I do, that just try to get this going. And I do just talk to them and just say, I need your address and your contact number. So then APA has a checklist. And so I'll just run through this kind of quickly so we can get on to some of the other things and have time to talk. And sorry, I'm a little winded. I was just running up the stairs there. So never a dull moment. See what I'm saying? There's always a crisis when you don't expect it. So I want to screen for appropriateness. So the APA checklist I have listed here, and it's also in the back in references, so you can get a hard copy of that if you want, or get it on the internet. But anyway, you want to look at clinical and cognitive status. Can the patient effectively participate? You want to know what's available technologically for the resources for video conference, webcam, or smartphone. Comfort in using the technology. Can they log in and effectively use the technology? You might spend a few minutes just helping them do that. And if you have IT support, that's nice. If not, then you're going to do the best you can with kind of just trying to do it. You want to know the available physical space for a private telepsychology session. Is a parent and guardian permission required? If so, obtain it. Will they be there at the time of the session? Will they be available? And if not, how can you contact them if you need to? And this patient's safety, including suicidality and health concerns, viral risk, mobility, immune function, community risk, and the psychologist's health, which is just as important as the client's health. There's a technology screen. Is your technology platform consistent with HIPAA compliant practices? Do you have a business associate agreement with that technology vendor? Here at the university, I rely on the university to do that, and they're using Zoom at this time. Do you and the patient have adequate internet connectivity? You can discuss with the client how to log in and use the technology. Are you using a password protected, secure internet connection, not public or unsecured Wi-Fi? What about your patient? If not, it increases the risk of being hacked. Did you check that your antivirus, anti-malware protection is up to date to prevent being hacked? And what about your patient? And are the updates on your computer done? Because you don't want to start having updates done in the middle of your session. Set check. Is the location private? Is it reasonably quiet? Make sure the room is well lit. Example, a window in front of you might cast a shadow or create low visibility. To improve eye contact, position your camera so that it's easy to look at the camera and the patient on screen. For those who do like the sessions with Tourette's, you begin to adjust kind of where you are in the room so you can see more of the body if you need to. Consider removing personal items or distractions in the background. Check the picture and audio quality. Can you see and hear each other? And make sure nobody is muted. As much as possible, both people should maintain good eye contact and speak clearly. So pre-session plan, we talked about this already, discuss the potential risks and benefits of telehealth sessions with the patients, get a signed informed consent from your patients or patient's legal representative. If the psychologist patient is quarantined, informed consent must be signed electronically, considered DocHub or DocuSign. Have a backup plan in case of technical difficulties and of a crisis situation. Secure contact information, local emergency resources such as emergency room, police for the patient. Discuss how the session will be billed. Will the patient be billed if late, no-show? Here, we don't bill for no-shows. In the case of minors, determine where the adult will be at that location. Determine where the adult will be at that location. So begin in the telehealth session, verify the patient's identity if needed, confirm the patient's location and the phone number where the patient can be reached. Review importance of privacy at each location. All individuals present for the virtual visit must be within view of the camera so the psychologist is aware of who is participating. Confirm that nobody will record the session without permission. Turn off all apps and notifications on your computer or smartphone. Ask the patient to do the same and conduct the session mostly like you would in person as much as you can. So that's kind of wraps up the part about just getting going in televideo, telehealth components. And we're just going to talk a little bit about the long distance training consultation and using Project Echo as a possible platform for that. So for those who aren't familiar to Project Echo, Project Echo means, ECHO stands for Extension for Community Healthcare Outcomes. It was launched in 2003, and the model makes specialized medical knowledge accessible wherever it is needed to save and improve people's lives, and it's being expanded as we speak. And the mission is to demonopolize knowledge and amplify the capacity to provide best practice care for underserved people all over the world. So some of its themes are moving knowledge, not patients. So through telementoring, ECHO creates access to high quality specialty care in local communities. There's a hub and spoke component to it. The hub is with experts, and the spokes are the partners or the people learning in the communities. So the hub and spoke knowledge sharing networks create a learning loop where the community providers learn from specialists, community providers learn from each other, and the specialists learn from the community providers as best practices emerge as they're beginning to talk about how does this happen outside of the platform or the center of expertise. So Project Echo's purpose is people need access to specialty care for complex conditions. There's not enough specialists out there to treat everyone. So ECHO trains primary care clinicians to provide specialty care services. So patients get the right care in the right place at the right time instead of having to do all the traveling and waiting and things like that for some of the expertise stuff. So the 4 principles of the ECHO model are use technology to leverage scarce resources, sharing best practices to reduce disparities, case-based learning to master complexity and monitor the outcomes. So Project ECHO shares knowledge and expands treatment capacity. The result is better care for more people. And what to expect during the clinic. A tele-ECHO clinic contains 2 main parts. There's the didactic that goes on for about 40 minutes, including about 5 to 10 minutes of questions, where it's a presentation by an expert or specialist on an issue related to the treatment and or the care. And then there's the case presentation. So participants present real cases to discuss with the network and receive advice from expert faculty. So basically, you're just talking to the providers about the case, and then the provider then is responsible for the care. So ECHO does not in any way provide direct care. So the ECHO model is an all teach, all learn model. Community providers learn from specialists and from each other. The specialists learn from community providers as best practices emerge. So, and okay, there's a comment, sorry. Can people still hear me?
Yep.
Yes.
Good. All right. So Project ECHO's federal partners are as listed. It's the Defense Health Agency, Department of Defense, Centers for Disease Control and Prevention, Indian Health Service, U.S. Department of Agricultural, Rural Community Development, Health Resources and Service Administration, that's HRSA, National Institutes of Health, Clinical and Translational Sciences Center, and Centers for Medicare and Medicaid Services. So this is one of the applications. If you go to the Project Echo site, you'll see that there's many applications there. But we've been doing this now for 3 years, and so we have the integrated cognitive rehabilitation psychotherapy. And on the slide, you see on this one on the left side of the slide is just the Echo model, where it's really, instead of having a one-to-one with traditional telemedicine, where the expert long distance sees a patient long distance, it's a one-to-one model. But in this model, you have the experts who are then training people out in the rural areas in the community how to do basics of the service, and then they see all the people they are working with. So there's what's called a multiplier effect. And then they know, the providers in the community know when and how to refer to the experts as needed. So it basically helps decrease the demands on the service and increase capacity. So what we did is we put together an integrative cognitive rehabilitation psychotherapy model. So it's a fairly complicated model, it has several components to it. And then we spent the first year, we had weekly sessions on this to look at rehab, and I'll go over the results to that. And then the second year, we then broke it into every other week sessions. And now this third year, we actually doing three sessions a month. Where the third session is what's called an up-to-date, where for people who've been participating for the last 2 years, and they kind of have the model, they're comfortable with the model, so now they want some new information. So we train on the model itself for the people who are just coming in, and then we offer something more to the people who've been continuing on. So the vision and goals of the Integrative Cognitive Rehabilitation Psychotherapy Echo Clinic was to disseminate best practices to clinicians so they are better prepared to provide evidence-based cognitive rehab therapy, increase knowledge and self-efficacy related to cog rehab psychotherapy through case-based education and mentorship, and improve utilization and access to cog rehab therapy resources in the practitioners community. And so there's just a slide of what the reach was of the clinic. When I started this clinic, it really was to just provide training for people in New Mexico, providers in New Mexico, but there weren't that many takers. So I put it on Division 22 listserv. And so then I basically, people from across the country, including Canada, had interest in it. So then we set a time that the West Coast and the East Coast in the middle of the country could actually all be working on it together. So we picked 10 a.m. Mountain time, and people from both coasts could participate. So in the first year, we did a survey and a participant survey. Okay, there was a question, and I guess we'll come back to that question, I think. Is that okay when we're done? I'll be done in just a minute.
That's right. We'll do that at the end. Thank you.
Yeah, that'll be great. So this was just after every session, we did a survey of how was the talk, and it just says that basically the talks are well received. And then we also asked at the end of the year, kind of how did you feel about the training and how's your competency? And almost all respondents reported topics covered were critical for practice, so good for a context setting, and an increase in their sense of competency after nearly a year of sessions after the first year. So it was a positive experience, and people like to do the video and the audio together. So Project Echo COVID-19, they are on Tuesdays, they have a 1 p.m. and a 9 p.m. Mountain Time session for people across the country to come in and talk about what they're doing. They have a presenter. Last week it was from UTSH, University of Texas Health Science Center at San Antonio, what they're doing. And so they talk about how they're trying to get the information out. And so they're sort of adapting the model, because what's nice about Echo is that there's a network in place. And so now it's available to address this crisis. So if you want more information, you can go to the echo.unm.edu/COVID-19, and that will get you the information. But how they're adapting is that they're using webinars now instead of this didactic case study piece at this point, because everything is really, we're just throwing it, there's a lot of information out there. And they're able to kind of have people jump onto these networks, and they're able to provide updates as you're going through it. So it's kind of a community that's just asking, how can we all do this together? And so with Project Echo, there's this great potential, and they talk about wanting to meet like 1 billion touch 1 billion lives, and it's global. So there's a lot of neat ways to do this. So you can use it to scale social initiatives in fields like healthcare, education, and social justice. And it uses proven adult learning techniques in interactive video technology. So it connects groups of community providers with specialists at centers of excellence in regular real-time collaborative sessions. And the sessions are designed around case-based learning and mentorship to help local workers gain the expertise required to provide needed services. So there's a lot of different variations on the theme. Some people do short, 5 or 6 sessions. AAP is doing one for concussion, and it's a 5 or 6 session format, depending on if you're in the school or if you're a provider in clinics. And other people are doing different types of clinics for a variety of different things, from pain to addiction to police appropriate behavior, community policing, education. There's a bone one. There's a lot of different clinics out there. Hep C was the first one. So in summary, telehealth has a long positive history. It's appropriately assessed if telehealth is the right platform for you and your patients. Thorough risk assessment and preparation is essential. Review information and guidelines for telehealth with patient and secure consent. So you're just comfortable with just kind of, it's a new way of talking to them, but it's just establishing the safety. And then Project Echo provides all teach, all learn format using didactic and case consultation. And Project Echo is providing long distance support through the COVID-19 pandemic. So that gets me to the end, and there's some references. And I did throw in a reference on how do you talk to people about mental health apps, because there was a nice article in Current Psychiatry on that. That's useful, I think. So if you're wondering about what to do with all these apps that people are using, this was a nice kind of guideline on how to look at that. So with that said, I guess I should stop sharing, and we could take questions if there are questions.
Yes. So thank you so much for sharing your expertise, Dr. Pedrotty. I feel like you covered a lot in a really short time. And I have to say, personally, I found the information to be really helpful and practical, and I understand how to move forward with it. So I thank you. There are a few questions that came to mind that I'd like to kick us off with just to start. And the first is just kind of backing out of the specifics here, thinking about people who may be starting in telehealth for the first time, as many people are, because of the time that we're living in. I'm interested to hear whether or not, when you're assessing whether somebody is appropriate for telehealth, if there's ever been a time where you've, maybe with a particular patient, determined that they're really not an ideal candidate for telehealth, yet the patient, because there are some benefits to it, not having to travel or whatever, that the patient maybe was still insistent on receiving services through telehealth. And do you have any advice for practitioners that might encounter that scenario?
Tracey, I think that's a wonderful question, so thank you. And at this point, I haven't had that experience, so I consider myself fortunate in that way. But if, just to kind of walk through that, there's several principles that can be helpful. The first thing is just to begin to explore, why is a person insisting upon that? And also, why does the clinician think that it's not good? So if a clinician comes up with a sense that this isn't going to be appropriate, then you begin to have that discussion with the person to say why that is. And you might find through that discussion that there's a way to continue to use the service. So I ask clinicians to at least be a little open-minded when they come to some sort of conclusion, to begin to explore that a little bit more and see. Now, if the clinician still says this is not going to work for whatever reason, there's several components to that. One is to suggest other ways that the person can get the services they need. And that is either go to local people, or that you're willing to, in some way, to help them make a connection to another site that they can actually do. So you begin to find a way to get them the services they need, instead of just saying, this isn't my bailiwick and I'm done. Unfortunately, I kind of play with the idea that if it's kind of like playing tag, if you've engaged a client and it's not going to work, then the question is how do you help them get the service they need? So you can actually try to figure out what those links are for them and what's available to them. It might not be ideal, but you're trying really hard to say, for me as a clinician, this is not going to work. And I think it's only fair for a clinician to have that right to say, this is not going to work for me. So hopefully that did some help in answering the question.
Absolutely. I think that's really helpful. You've provided a lot of helpful tips for getting started. And so, on that note, I'm also wondering if you have guidance to offer any of those folks out there who might be wanting to start telehealth and just exploring, well, what's an appropriate platform? I know there are a lot of options out there, and I'm certainly not asking you to endorse one specific platform, but I am wondering for those who are exploring their options, what do you think might be the top one or two things that somebody might want to be thinking about and really making sure they evaluate when they choose a telehealth platform?
Yep, that's another great question, and I'm sorry I didn't cover that. The issue with platforms is really, there's a really basic one, and that is just how are they protecting confidentiality? How well is it encrypted? And so you can ask the companies how well they're encrypting. You can go to your own kind of professional groups and ask them for any guidelines on what they're looking for in encryption. But there are some basic guidelines to encryption. And I remember a while ago, Skype looked really good, but Skype had something in the back room of it where it was encrypted, and that was all exciting, but they refused to then to deny that the Skype employees could actually look in on any ongoing conference or a meeting, and so that sort of nixed their confidentiality or their encryption component. So you really want to know just how well they're protecting confidentiality and how encrypted it is so that it can't be hacked. As you know, Zoom just got Zoom bombed, and then they put in some other pieces to it to keep that from happening. And there are, at least my colleagues have talked about this, there's at least three websites out there, or three platforms out there that are useful. So you can talk to your colleagues about what they're using, and then find one that's comfortable for you, because really you should be comfortable with it. Zoom is one that we're using here, and I'm comfortable with it because the universities purchase it, and it's fairly straightforward. But if I get stuck, I go to my administrative people and ask them if there's a problem with it, how they're going to work around it. So I don't have to go do that myself.
That's great. That's so helpful. So I see we also have a question from John Morris, who's asking about Project Echo. And John would like to know, how much do community providers share with each other without participation of experts in the hub? Are there mechanisms for that type of sharing? If community providers share informally, can some of that interaction be captured or reported in order to enrich the entire system?
That's a great question. And if I understand it correctly, how much is the community engaging in the discussion, and how much does that carry on? If I can speak for the model that we're using, and that is when we first got started, the participants didn't feel that comfortable talking as much. So the first few sessions when you get going, the experts are doing a lot of talking, but then once everybody begins to settle down and begin to feel comfortable and know they all have something to contribute, and then the person who's leading the session also has to encourage people to talk. I joke and I say, okay, I'm going to use my clinical skill of counting to 20, because it takes people some effort. But in the big picture, once your community begins to feel comfortable with each other, they all start sharing of what they know, and then they help each other, and then those go into the notes as to the clinical consultation of here's some suggestions that people make. So the community begins to grow and feels comfortable with helping each other and sharing what they know as the participants. And then the experts, their job is to not run over people, but to support what also is going on.
Thank you. So, that made me think of another question, and perhaps you covered this and it just didn't completely register for me, but how does somebody become part of the community and receive support through ECHO?
So I did not cover that, so I don't think you missed it. So Project Echo has several different elements to it. If you want, you can basically go to their website, and then they will encourage you to come to their trainings, and they're doing some of their trainings long distance now. But they have training sessions to teach you about the model and how to use it, and how to use something called iEcho, which is a way that they track kind of the use of it and have data. So they teach you about that. So going through the Echo Institute is really a good way to get started. If that's something that is more daunting or you don't have time for, then you can talk to people either at super hubs across the country or people who've done an Echo, and you can begin to build that with them. Or you can sit on an Echo, like anybody could sit on the Echo that we do, and you could see if it feels right for you and if it could fit for what you want to do.
And are there any limitations for international viewers in participating in Echo? Is there a requirement that the person be in the same country as Echo is located, which is the United States?
No. As far as I know, no. If I'm wrong, then someone's going to have to correct me. But like for here, when we had people coming in from Canada from time to time, and that's fine. It's so the only thing that you at least acknowledge when you have people coming in from other countries is just how the systems might be set up. The rules might be different in those countries, and again, it just depends upon what you're actually training on, or as a community, what you're learning together on. So you begin to just roll in the culture you're in or the community you're in, and how what you might talk about might be different if you're in a different community. So when Canada's participating, they're saying, well, healthcare is different here. You appreciate that, but then in the clinic, the issues might be very similar.
Great, and I'll ask you one last question, and while I'm doing that, if anybody has a question on their mind that they haven't asked yet, I would encourage you to write it or type it into the chat feature. And so the last thought on my mind is I'm going to back up again to kind of the broader picture, and I really appreciated all the information you provided about the safety assessment and risk assessment, and I know that a lot of that was based on guidelines that are developed and provided by the American Psychological Association, and it is really intended for providers who provide psychological care. Those of us in other disciplines such as speech pathology, physical therapy, occupational therapy may not have the same requirements of our associations. However, given that the people that we serve may experience psychological crisis, even if that's not why we're treating them, would you still recommend that non-psychological service providers consider following a similar safety plan and format?
Another good question. You're on fire today, Tracy. So my bias goes like this: if someone is in crisis in your office, and you can figure out how to manage it, that's great. If someone gets in crisis outside of your office, and it can get actually deadly or fatal, you probably will lose some sleep over that. So to me, from a comfort zone, if you have a client telling you like that's never going to happen, that's great. But the funny thing with mental health is that sometimes it's very hard to predict who's going to go off the rails or not on you. So if you just had that in place, just to say, we work together and everything's fine, but if there was a crisis, how could I get someone to come to your house? And then you can figure out, when you say crisis, it could be medical, or it could be emotional, or psychological, or somehow they could be being abused, and you weren't even aware of that in your office until like all of a sudden now you're in their home. So I would rather be safe than sorry, and just try to gently say, if for some reason something were to happen, how could I get someone to help you? That would be my kind of fallback, if that seems comfortable enough. I'd be curious to see what you all think about, like, is that just a psychologist being overreactive, or what do you all think as well?
Yeah, if anybody would like to respond to that in the chat feature, please do. I'll go ahead and comment and say that that makes perfect sense to me. I don't have a psychology background, but I am a speech language pathologist, and certainly I know that all people experience psychological problems from time to time and may need support, and it makes sense that that could happen at any moment. So I think I'll be giving that a bit of thought in my own practice and talking with some of my speech language pathology colleagues about this, about what level of safety plan might be appropriate to add, because I certainly wouldn't want to be in a situation where something came up and seemed emergent, but I didn't already have a plan in place to react. That's particularly difficult when you're providing services remotely and you can't, see and be with somebody. So, and also most of the time when people provide services remotely, in many situations, the provider themselves may not be around other providers that they can quickly interact with for support or guidance. So having that plan firmed up ahead of time really sounds like a great idea to me. And I'm so glad to have learned about that advice and guidelines from the APA and from you today. So thank you.
Thank you.
All right, and I see we don't have any other questions in the chat feature, so I'd like to again thank you, Dr. Pedrotty, for sharing your expertise with us. This was just so informative and so important to get this information out there, especially during the time that we live in right now. And I want to thank you also to everyone listening. We appreciate you attending and invite you to join future webinars. All the recordings, including this one, will be available in the next 24 hours. Please do recommend your colleagues to the webinar and repost to your social media circles. And this concludes our episode for today. Be safe, stay healthy, and we hope to see you next time at the next ACRM Pandemic Webinar Series.